Bismillahirrahmanirrahim. Qalu subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. We'll be starting today a new topic called airway management. It comprises of two portions, part 1 and part 2. Part 1 will be again, for part 1 will be 2 lectures will be delivered, and for part 2 2 lectures will be delivered. It means on the whole airway management will be in 4 lectures. Now, topics for discussion in this part 1 are: how is the airway maintained and what are its objectives? And before that, what is the airway anatomy and physiology, causes of respiratory difficulty and diseases, and distress caused by the difficult breathing, and how we assess the respiratory function, methods of airway management, methods of ventilatory management, common out-of-hospital equipment utilized, advanced methods of airway management and ventilation, and risks to the paramedics, which do not exist in our country. Now, primary objective of airway management is we want to make it sure that there is optimal ventilation. Optimal ventilation means we are delivering oxygen to the blood and we are eliminating the carbon dioxide. That is the whole objective of respiration and whole objective of ventilation. That we have to make the oxygen reach the blood and we have to take the carbon dioxide out. So we'll define first what is the airway management and how does it differ from spontaneous, manual or assisted ventilation. Why is this so important? Because if there is a lack of oxygen, it can cause brain death in 4 to 6 minutes. Why 4 to 6 minutes? If any person who arrests, the total amount of oxygen which is present in the body will be 1000 mil to 1500 mils. And we require, an adult requires about 250 mils of oxygen per minute. If you divide 1000 or 1500 by 250, it will be 4 to 6 minutes. Now, if we can manage airway within this period, we can save the brain and we can save the other organs also, because our whole objective is to save the brain first. So, within 4 to 6 minutes, if the 6 minutes has gone, because there is a lack of oxygen, so there is no point resuscitating the patient, because even if the patient recovers, he will be brainless person. Then we have to take the carbon dioxide out also. So for that purpose we need to be breathing. For oxygen can travel. Now there are two parts. Oxygen reaches from air or from the oxygen source to the alveoli, and it will go on reaching because diffusion of gases in the gaseous media is inversely proportional to its solubility coefficient, inversely proportional to its molecular weight. And from alveoli to the blood, it according to the solubility coefficient, that is according to Henry's law of diffusion, that diffusion of gases in the liquid media is directly proportional to its solubility coefficient. Greater the soluble, the more will be diffusion. So carbon dioxide is much more diffusible as compared to oxygen. So once the carbon dioxide comes into the alveoli from the blood, then we need to ventilate or we need to breathe to bring it out. Otherwise, it will not automatically come out. Now, anatomically, we divide these airways into upper airway anatomy and lower airway anatomy. There's always a confusion, and different authors, they divide in different ways. Now, then we have to look at the lung capacities and the lung volumes, and there are pediatric airway differences from the adult ones. Now, in upper airway, it starts from the nose or from the mouth up to the end of the larynx, as per definition. Then lower airways start from the larynx or the cricoid cartilage up to the 16th generation, that is up to respiratory bronchiole. From respiratory bronchiole, that is up to the alveoli, that is 23 generation, from 16th generation to 23rd generation is a area where the diffusion of gases takes place, where the blood comes in contact with the gases. So in this, you all know, it passes through the nose, then goes into nasopharynx, then goes into the oropharynx, then goes into laryngopharynx. Before it goes to laryngopharynx, it goes into the larynx, and there are different parts of the larynx also. It passes through the laryngeal aperture and goes into the trachea. Then, what is the function of upper airway? Why the nature has put in such a way? The most important function is it warms the air, it filters the air, and it humidifies the air. The purpose of nose, जो यहाँ पे रखा हुआ है, it is a condenser humidifier. Nose is a condenser humidifier. Or you can have an artificial nose also put over there, which will, because if you see in the nose, there are irregular spaces, turbinates and other things. It comes in contact with the warmth. So the air is warmed while going back into the lung, and there are hairs also, and they also function. They filter the big molecules of dust and other things also when it passes through the nose. So that's why we always tend to breathe through the nose also, because it is warmed and then it is filtered, and then it's also humidifier. In the expired gas, whatsoever is the humidity, is the water is deposited into the nose, and when you on a subsequent inspiration, and that will humidify again, and the same gas, same humidified gas goes into the lungs. Nasal cavity and nasopharynx is formed by the union of facial bones, and nasal floor is towards the ear, not towards the eyes. So when you are putting a nasopharyngeal or nasogastric tube in, you should always remember it, because it should not go like this. When it goes into the nasal cavity, it should go like this also, because it flows towards the ear, directly towards the ear, not towards the eyes, because that's the direction of the nose, like this. It's lined by the mucous membrane, cilium. Tissues are delicate, vascular. Otherwise, when you are putting the nasogastric tube, the patient usually bleeds because of our lack of experience or because of our mishandling the patient. Then there are adenoids on the both sides also. They are lymph tissues. They filter the bacteria. Nothing in the body is unimportant. Yeah. They always say that these adenoid tissues are useless. It's not useless. It's a lymph tissue. It filters the bacteria. So if you have got adenoidectomy afterwards, you will realize that you always get the sore throat, and you always tend to get the infection also. And it is commonly infected also, because it's just behind it is in the nasopharyngeal area. Any person who cuts the hair in the nose will get more infection as compared to the person who doesn't cut the hair in the nose, because the nose is also very good to filter the air which is going inside. So everything in your passage is very important, and nature has put with some function. Now, oral cavity and oropharynx, it has got teeth and tongue. Now, and the palate. The palate has got two parts also. Then teeth, what is the function of teeth? Is you chew the food with the teeth. And tongue is attached to the mandible and the hide bone. And most common airways are due to obstruction caused by tongue. And tongue is bigger in case of ladies as compared to adults, as compared to males, because they use quite a lot. They are always talkative. So third function of this tongue is, in the case of ladies, is talking, right? So then the palate has got two portions. It's got hard palate and a soft palate also, right? Then there are, in the oral cavity and oropharynx, there is a tonsils on the both sides. It also is a lymph tissue. It filters the bacteria. And it is also commonly infected. So if you take this lymph tissue out, you always get sore throat afterwards, after the tonsillectomy. Then you got epiglottis also. Now it's a leaf-like structure. It closes during swallowing. When you are swallowing the thing, it closes and closes the laryngeal aperture so that the food can go into laryngopharynx and then goes into the esophagus. It prevents aspiration, obviously. Then vallicula is the two pockets. Vallicula is the portion which is at the junction of posterior part of the tongue with the epiglottis. And there are two piriform fossas on the both sides. So vallicula is also very important. When we are intubating the patient, our tip of the laryngoscope should be in the vallicula. It should be lifted upward and forward. Then you see the laryngeal aperture down. Now this is typical when you look at the anatomy. When you put the laryngoscope in and when you ask the person to open the mouth. Larynx is attached to the hyoid bone. It is horseshoe shaped and it supports the trachea because the trachea is attached with the larynx. And the thyroid cartilage is in front of your upper part of the trachea and on the larynx. So it is the largest laryngeal cartilage and shield-shaped cartilage anteriorly, smooth, and muscle is posteriorly, because it's not a circular cartilage. It's like a soft tissue on the back. Anteriorly it has got cartilage. That's why when we are intubating the person who has eaten something, so we want to close the esophagus, we always push the cricoid back, because cricoid is like a signet ring. It has got broader portion on the posterior aspect, so it can compress the esophagus. But cartilage cannot, thyroid cartilage cannot completely obstruct the upper part of esophagus. And in some people, it's a very prominent thyroid cartilage called Adam's apple. Now, behind the cartilage is a glottic opening, which is directly behind it. So, if you put the laryngoscope in and your tip of the laryngoscope is in the vallicula, you lift it upward and forward, so it automatically, epiglottis will be lifted up and you can see the laryngeal aperture there. It's very easy to pass a tube. Larynx is a glottic opening. Adult airway is the narrowest point. Laryngeal aperture is the narrowest point in adult of the airways, but the narrowest part in case of neonates is the cricoid ring at the cricoid cartilage level. So that's why we choose such a tube which should not damage the cricoid, mucosa around the cricoid, because it becomes edematous, it can cause obstruction very quickly. And any tube which can pass through the larynx in adult can pass into the trachea. So in case of neonates, if the tube can pass through the laryngeal aperture, it doesn't mean that it can pass through the cricoid ring, because that is the narrowest part. Now, arytenoid cartilage is posteriorly attached to the vocal cords. So this we don't want to go into detail. Now, cricoid ring is the first tracheal ring, and it is completely cartilaginous, and the compression, when we put the pressure on the cricoid, so this maneuver is called Salix maneuver. And how much? It's a Salix maneuver when you are talking about intubation and applying the pressure on the cricoid, and when you are applying with the Salix maneuver, so there are quite a few steps you should be knowing. Who will you put in the pressure? Where will he stand? How much pressure will be applied? For how long the pressure will be applied? And what instruction you will give to the person who is applying the cricoid pressure? It's very important, and it's always asked in the exam when there is an intubation, even in FCPS 2 also. Not to talk of only the diploma or MCPS, but in FCPS also quite a few people fail, and they cannot completely tell you the section wise that whom you will give instruction, how will he stand over there, how much pressure he will apply, for how long he will apply the pressure, and what instruction he will give to the person who is applying the Salix maneuver. Now, cricothyroid membrane is very important. It connects the cricoid cartilage to the lower end of the thyroid cartilage. And this is a very important part because it is a membrane. So, if the person goes into airway obstruction at the laryngeal level, you can always pierce with a needle and you can make a hole over there. And when you are doing retrograde intubation also, now you go through the cricoid cartilage also. You take a big needle, or especially the 2-inch needle, and the bevel should be directing upward, and you go into the trachea at the level of cricothyroid membrane. And then you pass the stellate through that, and stellate would appear in the mouth, and over the stellate you pass a tube, and you can, this is called retrograde intubation. Now, carotid arteries, these are the branches across it, and valley lying alongside the trachea. Jugular veins also lying alongside the trachea. And this is gross anatomy of the larynx and upper airways you should be knowing. Then the nerve supply and other things. This is how it looks. This one. This is epiglottis, and it is the tongue behind this epiglottis where it joins the tongue. So that's called vallicula. You lift it like this, and you can see the vocal cords. And through the vocal cord we pass the tube. Now, lower airways have got two parts. Lower airways starts from the respiratory bronchiole. So, lower airways, according to this, we start from the cricoid cartilage below up to the 17th generation or 16th generation, which is called respiratory bronchiole. These are only just a conducting tube. And once the air goes there, and from the respiratory bronchiole up to the alveoli, this is called respiratory unit, where the gas exchange takes place. So the air, as long as it is up to the respiratory bronchiole, we call it as the dead space portion. And the portion of this respiratory tract from the respiratory, from this 16th generation up to 23 generation, that's called respiratory portion, because the gas exchange is taking place. Now, function of lower airway is to exchange the oxygen and carbon dioxide in the respiratory portion, not in the first portion, that's the portion. Now, the whole lower airway starts from the glottic opening to the alveolar capillary membrane. Now, when the gases go into the alveoli, so in the alveoli, you have got alveolar epithelium, then you have got subcutaneous tissue, then you have got space, then you have got capillary epithelium, and capillary endothelium, and then it goes into the blood. So this is called alveolar capillary pathway. The gas has to pass from alveoli through all these, because it's all water, goes into the blood. There in the blood, oxygen combines with the hemoglobin, depending on the oxygen dissociation curve mood, whether the hemoglobin is in a mood to accept the oxygen or not. Trachea bifurcates at carina. There are two portions like this. Because the bifurcation, right, left, main stem bronchi, they are called bronchi, right and left. And right main stem bronchus is shorter, straighter, and at the angle of, at what angle it is? Because if you take the trachea like a straight line, then the right bronchus going like this, it is at the angle of 25 degree. On the left side, it is at the angle of 45 degree. Why it is at 45 degree? Because we have got the heart on this side, it is pushing up the trachea. Because when the baby is born, they are equally angled. But as the baby becomes bigger and bigger, the heart size also increases, it pushes the left bronchus upward. So then it is 45. Once the right bronchi is at 25 degree, so most of the foreign bodies, they tend to go into the right lung, and they also go into the left lung also, depending on in what position you are when you are aspirating. So aspirate mostly goes into the right lung, very little goes to the left lung. Then it is lined with a mucus cell, or beta 2 receptors are there. As far as autonomic nervous system is concerned, beta 2 receptors are lying in the trachea and the bronchi. Bronchi, they branch into secondary, tertiary bronchi, that branch into bronchioles. Go on division, go on. They are small and small and small till they become the alveoli. Then the bronchioles, there is no cartilage in the walls. Small, smooth muscle tubes branch into alveolar ducts, that at the end at alveolar sac. In the alveolar sac there are alveoli. छोटे छोटे थैले से बने होते हैं. जो ही आदमी बड़ा होता है या उसको लंग की प्रॉब्लम होती है, सेप्टा टूटने शुरू हो जाती हैं. They become bigger. When in the septa you got the vessels also. So in septa also there is diffusion of gases are going in. Oxygen being absorbed and carbon dioxide being diffused into the alveoli. So as the septa break up, it becomes a big hole. So it increases dead space. It will have a dead space effect. Alveoli, they are balloon-like clusters. जैसे अंगूर की तरह गुच्छे पड़े होते हैं उसके alveoli के. The sites of, these are the main sites of gas exchange. They are lined with a surfactant. Surfactant is a surface tension lowering agent which is produced by these alveoli, and the respiratory tract has got 43 types of cells in the lung. And there are two main types of cells. One is pneumocyte type 1 and pneumocyte type 2. Pneumocyte type 1 is for the exchange of gases, and pneumocyte 2 is for the production of surfactant. 95% of the mass is of the type 1 cells. They occupy 95% of the area. 5% is only occupied by the type 2 cell. But if you measure if you weigh these, so this 5% is greater than the 95%. So the surfactant produced start being produced at the 22nd week of gestation. When the baby is in the uterus, is developing, at 22nd week, it starts producing surfactant. It means before 22nd week, the baby cannot survive. At 33 weeks, there are surges of release of surfactant. Then the baby's lungs start expanding, right? So when the baby is born, so surfactant is already collected there. When they start their breath, first breath, they create a negative pressure into the thorax, the alveoli open like this, and they remain open because of presence of surfactant. So if there is less production of surfactant, or the baby is premature, and they tend to go into ARDS type of picture, and they are given artificially surfactant also. आपने देखा होगा ये neonatal units में और नर्सरी में देते हैं वो pediatrician. So if there is a less surface production, surfactant production, the alveoli tends to collapse. So this surfactant is very important. Now, whenever you put the patient on a ventilator, there are three things we have to consider. First thing is three types of trauma you can give to the patient. One is barotrauma, then volutrauma, and third is biotrauma. Barotrauma means because of pressure. If you are putting a high pressure, it will burst the alveoli and it will cause pneumothorax. Volutrauma is even if it doesn't increase the pressure due to stretching because of large volume which is going into the alveoli. So the gases can pass through that stretched alveoli also. It can also cause pneumothorax. Biotrauma is because our cells, our lungs, our body is used to negative type of pressure breathing. Because when we breathe in, we create a negative pressure in the thorax, then the gases are sucked in. When we are putting the patient on ventilator, we are putting the gases under pressure. So our body is not used to that. So because of that, there is a disturbance of cells, different types of cells in the lungs. They produce different type of chemical substances. Some are increased more, their production is more, and some cells stop producing the desired amount of substances. So that's why it becomes strange picture. So when the patient goes into ARDS, it's very difficult to control them because different type of biomarkers or substances are produced, and according to symptomatology you control the patient, and there cannot be set line that this particular patient, that every patient should be put on such and such mode. So we'll have to change the mode with change the different parameters of ventilator on individual patient. It is your assessment. Now in lungs, there are two lungs, probably you know it, right lung and left lung. Right? In right lung there are three lobes, upper, middle and lower, and the left lung there are two lobes. So it is a parenchymal tissue, and it is a covering which is called pleura. We call it visceral pleura, and there is a parietal pleura also, and the space in between them is a potential space, because the pleura slides like this. Both layers of pleura slide like that during inspiration and during expiration also. So if you this potential space, if you breach this potential space, if some fluid is produced inside, that is called pleural effusion, that will make the space bigger. Or if the gas leaks into this, it will cause pneumothorax. It will also expand the space. So if there is infected, if your pus goes into that, then it's called it will also increase the space. So that's very important. Normally there is a negative pressure space, or you will say they slide over each other. Lung volumes and capacities. Typical adult male total lung capacity is 6 liters. Suppose you are breathing, and with every breath you are putting in or you are sucking in the gas about 500 ml, and your breathing rate is 12. You multiply 12 with the 500, it becomes 6 liters. 6 liters in a minute gases are going into lung. How much remains in the dead space area and how much goes into respiratory area? About 1/3 is in the dead space area. It means 2 liters will stay in the trachea and up to respiratory bronchiole, and 4 liters will be in the respiratory bronchiole and below that area. So the 4 liters will be exchanging the gases between the blood and between the respiratory space. So that is a useful area. Now usually 5 to 7 cc per kilogram is typically tidal volume which we consider. Now this, if you take it, so total minute volume is 6 liters and the respiratory portion gets 4 liters. How much is the blood coming into the lung? The total blood volume passes through the lung. And how much is the total blood volume which is coming into the lung? So about 5 liters. Every adult has got 5 liters of blood, and in 1 minute it passes through the lungs. It means 5 liters of blood will come in contact with the 4 liters of gases which is going into the respiratory portion of the lung. So 4 liters divided by 5 liters, so what will be the answer? 0.8. It is called ventilation perfusion ratio. Now this ventilation perfusion ratio is normal ventilation perfusion ratio. It means there will be proper exchange of oxygen going into the blood, and the proper amount of carbon dioxide will be coming from the lung into the alveoli and vented out. So if there is a disturbance of ventilation perfusion ratio, for example, if you are putting more gases into the respiratory portion, for example, you put 6 liters there and 2 liters or 3 liters in the dead space, and the blood is only 5 liters coming. So it means some of the gases will not come in contact with the blood. It means it will act like a dead space effect. So there will be ventilation perfusion ratio will be disturbed. So there will be more dead space effect. Now if there is more blood coming and some of the alveoli are not open and the gases are not coming in contact with that, so some of the blood will not be taking up the oxygen and will not be delivering carbon dioxide to the alveoli. That is called shunting of blood. So blood will be just passing through the lung, not coming in contact with the gases. So it will be unsaturated blood which is going. So that's called shunting effect. So we have to normalize like this. Every person who is born should have ventilation perfusion ratio of 0.8 and not a whole lung. individual lung should have the same ventilation provision ratio. Not only the whole lung, each lobe should have a same ventilation provision ratio. Not only the lobes, each alveoli should have a ventilation provision ratio of 0.8. It's very difficult to find that person up till now. Nabiyon mein hoga, lekin when the child screams and breathes, it opens up the lung, so we presume their ventilation provision of every part of the lung have got a ventilation provision ratio of 0.8. Then there will not be problem with the oxygenation, there will not be problem with the ventilation. That child will not need any oxygen at birth. Why we give oxygen at the birth is because they have not opened up all their alveoli. The blood is just bypassing. Ventilation provision ratio is not normal. Till pediatrician is satisfied that now child's lung is completely expanded. In other words, now the child's lung has got ventilation provision ratio of 0.8. Now we should stop giving oxygen to the baby. Right? Iski physiological basis here. Now tidal volume. What is tidal volume? It's the amount of gas which you take in or expired out per breath is called tidal volume. Dead space is 1/3 of the tidal volume. If you are breathing in 500 mils, इसका 1/3 जो है डेड स्पेस में रह जाएगा, तो 2/3 आगे जाएगा. So it means 150, round about 150 will not come in contact with the blood. Only 350 will come in contact with the blood, and that will normalize the ventilation provision ratio. So that will deliver oxygen and take up carbon dioxide and come back. Now again, dead space is two types: anatomical dead space and physiological dead space and pathological dead space also. You go on dividing as you like, but dead space is a dead space. Dead space is a space where the exchange of gases doesn't take place, right? Anatomical dead space in the trachea and the bronchi up to respiratory bronchiole, 17th generation of the lung division. Then physiological dead space is if you have got blood is not coming into the lung, even you are at the alveolar level, so that also becomes dead space because the air or the gases are reaching the alveoli, but blood is not coming to take up. It means that gas is a dead space gas. Right. Then pathological is like disease or obstruction, for example, COPD. In COPD, there is septa between the alveoli that breaks up. So it means you are reducing the area of diffusion of gases so that most of the gases will not come in contact with the blood. So that is a dead space effect. In COPD, this dead space is increased. That's why they retain the carbon dioxide. You cannot wash out completely carbon dioxide. Alveolar air reaching the alveoli for gas exchange. So that is 1/3 in the dead space, 2/3 into the alveoli, or the place where gas exchange takes place. Is usually 350 cc out of 500, right? 500, 150 remains in the dead space, 350 goes into the diffusing area of the respiratory system. Minute volume. If you multiply the tidal volume with the respiratory rate, that becomes minute volume. With one breath, you are taking 500. If you are breathing at the rate of 12 per minute, it becomes 6 liters. Your minute volume is 6 liters. 2/3 is going into the gas exchange area. 1/3 remains in the dead space. It means the 4 liters going into the alveolar area. 2 liters remain in the trachea and the bronchi. So the gas which is going into the from respiratory bronchiole up to the alveoli, that is called alveolar minute volume. Here, just मैंने कहा 6 liters you are breathing in per minute. 4 liters will be in the alveolar area where the gas are exchanging. That is called alveolar minute volume. And the total minute volume is 6 liters. And dead space minute volume is 2 liters multiplied with the 12, about 2,400. But a simple mathematical calculation there. These are very important when we are ventilating a patient. When we are ventilating a patient, or you are artificially supporting the ventilation of the person. Functional reserve capacity. What is functional residual capacity? What is the closing volume? At the end of, when you breathe out, how much is left? How much is left in the lung? And what is that called? Functional. So if you combine residual volume with the functional residual volume, that is called functional residual capacity. So it's a volume above the residual volume, which is called closing volume, at which the alveoli starts closing. You've got residual volume, then above that some volume, and then above that the alveoli starts closing. So the total gas which is present is called functional residual volume or functional residual capacity if you multiply it with the rate. So it is a volume above the residual volume after normal expiration, which that is called closing volume. And closing volume is very important. When we apply the PEEP, we increase the functional residual capacity because we want to keep the alveoli open. We want to keep the alveoli open so that gas exchange is going all the time. So we want to increase the area through which the gases are exchanging. Right? So closing volume is one of the tests of obstructive airway disease. So what is the inspiratory reserve volume? Normally you are breathing 500 ml in. It is a forced inspiratory volume above the tidal volume. This is called inspiratory reserve volume. Same way, expiratory reserve volume also. After normal expiration, if you forcibly you take it out, the gases, so that is called expiratory reserve volume. The only thing which is left will be the only residual volume. That cannot be expired out. It doesn't matter how much effort you make. ये typical book में आपने देखी होंगी इस किस्म की पिक्चर बनी. That ये picture this is very important in your physiology book or in nursing हो या डॉक्टर का हो, तो इससे आपको पूरा concept बनता है. What is the inspiratory reserve volume, expiratory reserve volume, what is total lung capacity, what is vital capacity, so on. What is the closing volume? So and that gives you concept. Ventilation. There are two terminology we use, ventilation and respiration. You all people sitting here, you are breathing, and this breathing is a negative pressure breathing, and this is called respiration. Because when your respiratory muscles, inspiratory muscles contract, they pull the chest out, and that creates a negative pressure in the pleural cavity. So the pleura is pulled out, the lungs are pulled out, that creates subatmospheric pressure into the lung. So atmospheric pressure higher than the subatmospheric pressure, due to pressure gradient, the gases are going into the lung. This is called respiration. So things always flow, whether it's a liquid or a gas, due to pressure gradient, due to pressure difference. Pressure difference is different thing, pressure gradient is different thing. So due to pressure difference, and things always flow from higher pressure to lower pressure. Right? आप पानी डाल दें फर्श पे, कभी देखा पिलर के ऊपर चढ़ रहा हूँ, अगर पिलर पे डालें तो फिर नीचे ही आएगा. ठीक है. So वहाँ ऊपर ज़्यादा प्रेशर है इसके. So things always flow whether it is a gas or a liquid due to pressure difference. So in case of respiration, you create negative pressure or subatmospheric pressure into the lung. So now the pressure is greater outside as compared to inside the lung. Due to pressure difference, the gases are going into lung. Now when we are putting the gases with the pressure, with the ventilator, we create higher pressure as compared to the normal pressure in the lung. So there is a pressure gradient. So then the gases go into the lung. That's called ventilation. So that's the difference between ventilation and respiration. So any device which pushes the gas into the lung because of creating a pressure is called a ventilator. Any device which gets the gas into the lung because of creation of negative pressure into the thorax, that is called respirator. Don't mix them up. Respirators are negative pressure breather, and ventilator is a positive pressure breather. Now this respiration, which is ventilation or respiration going into the lung, is controlled by center in the medulla normally. Then a pneumothoracic center and hemotoxic centers also in the pons. They control it. It's a separate topic itself. Now there are respiratory drives also, chemoreceptors in the medulla, अल्लाह मैंने वहाँ रिसेप्टर रखे हुए हैं which are controlled by body temperature. When the fever is increased, is the respiration. When the patient is in the induced hypothermia or becomes cool, so then it suppresses the respiration because through the chemoreceptors. Then some drugs and medicine also increase or decrease the respiration. Pain, because your painful stimuli, they start breathing fast. So pain increases, but occasionally decreases also. You don't shock the patient with the pain. If you shock the patient with the pain, it will decrease the respiration, right? Then emotions, they increase the respiration also. The acidosis also stimulates the chemoreceptors in the medulla and they increase the respiration. Sleep, it decreases the respiration. Now total pressure, atmospheric, how much is the pressure you are under in one atmosphere pressure equal to 1 torr, right? Then if you measure in pounds per square inch, 14.7 pounds per square inch. If you measure in kilopascals, 1 kilopascal per square centimeter, 1 kilogram per square centimeter, right? If you measure in pascals, 10 raised to 5 pascal equal to 1 atmosphere is equal to 1 bar. So there are different units of measuring a pressure. So हम millimeter of mercury usually देखते हैं. Otherwise 7.5 millimeter of mercury is equal to 1 kilopascal. इसलिए जब आप ब्लड गैस एनालाइजर का आता है ना उसमें आपको मिलीमीटर ऑफ मर्क्यूरी मिलेगा तो वहाँ पे हम बाज़ दफ़ा किलो पास्कल से मेजर करते हैं. फिजिक्स के लिहाज से व्हाट इज़ द प्रेशर? इट इज़ द मेजरमेंट ऑफ मॉलिक्यूलर बम्बार्डमेंट ऑन द लेटरल वॉल ऑफ द कंटेनर्स. किसी भी बर्तन में आप रख दें उसका प्रेशर कैसे बनता है? बिकॉज इट इज़ द measurement of the, or it is a measure of the molecular bombardment on the lateral wall of the container, that is called a pressure. It is a force per unit area. Mathematically, force per unit area. If you have force per unit length, that is called tension, surface tension. Force per length, per unit length, that is the surface tension. Force per unit area is the pressure. Now, in a mixture of gases, individual gas exerts a pressure, same pressure as their proportion is in the concentration. For example, gases which are around you, which are exerting 760 millimeter of mercury, in that you have got 21% of oxygen, 79% of nitrogen, बाकी छोटी मोटी ऐसे हैं. तो ऐसे रफली हम कह लेते हैं. If 20% oxygen, 79% nitrogen and the rest is carbon dioxide and depend करता है किस polluted area में आप हैं. Now this is the concentration. This is called FiO2 concentration. हम कहते हैं कितनी FiO2 दे रहे हैं. That means we are asking what is the concentration of oxygen you are giving to the patient. 10%, 20%, 30%, 40%, 50% जो हम देते हैं. लेकिन उनका प्रेशर कितना होता है? इस एयर में अगर 20% ऑक्सीजन है, how much is the pressure of oxygen in this 760 millimeter of mercury? 20 divided by 100 multiplied with 760 minus the vapor pressure. 760 is the pressure of the gases plus vapor pressure. इसमें 47 होता है वेपर प्रेशर. वो 47 निकाल देंगे, बाकी कितना बच गया? 713. दिस इज द प्रेशर एक्सर्टेड बाय द गैसेस. इसको मल्टीप्लाई करें 20 क्योंकि परसेंट है, उसको डिवाइड करें 100 पे, इट विल कम्स आउट टू बी 145 to 149, समथिंग लाइक दैट. सो दिस इज द प्रेशर विच द ऑक्सीजन एक्सर्टिंग ऑन यू when it is at 20%. With the same pressure the gases are going into trachea, going into the alveoli. When it goes into the alveoli, carbon dioxide is coming from the blood. That is diluting it. Now the same 149 pressure now here becomes 108 or 110. This is called partial pressure of oxygen in the alveoli. Now the same oxygen now diffuses through the alveolar capillary pathway, goes into the blood. Definitely, because things always flow due to pressure gradient. Alveolar pressure should be higher than the pressure in the blood. So there it exerts 100 millimeter mercury. So partial pressure of oxygen in the alveoli is 110 or 108, and partial pressure of oxygen in the blood is 100. This is taken as a partial pressure gradient, AA gradient भी कहते हैं. So देखिए वहाँ से 149 से शुरू हुआ, alveoli में जाके 110 हो गया, ब्लड में जाके 100 हो गया. ये ऑक्सीजन कैस्केड ऐसे चल रहा है. जब ब्लड में जाएगा टिश्यू पे और कम हो जाएगा, और जब टिश्यू के अंदर चले जाएगा और कम हो जाएगा. ठीक है, इस तरह कार्बन डाइऑक्साइड कैसे बिल्टअप होता है. दिस होल थिंग इज कॉल्ड ऑक्सीजन कैस्केड. ठीक है, ये बड़ा इंपॉर्टेंट है हमारे लिए. नाउ व्हाट इज रेस्पिरेशन? इट इज एक्सचेंज ऑफ गैसेस बिटवीन लिविंग ऑर्गेनिज्म एंड एनवायरनमेंट ऑन द होल. External respiration is exchange between the lung and blood cell. Internal respiration is between the blood and the cell. So, जब आप लंग से ब्लड में जाती है ऑक्सीजन, this is called external respiration. When it goes, the blood goes to the tissue. When there is exchange of gas from between the blood and the tissue, this is called internal respiration. So, external and internal respiration. How is the oxygen and carbon dioxide transported? Now, oxygen from the alveoli, from the atmosphere, passing through the conducting pathway, going up to the alveoli, it's all tube. Okay? Now, this oxygen is passing in a gaseous media. Here we apply the law of physics, which is called Graham's law of diffusion. Now, Graham's law of diffusion is diffusion of gases in a gaseous media is inversely proportional to its molecular weight. Any gas which has got greater molecular weight and other gas has got less molecular weight, for example, oxygen has got O2, its molecular weight is 32, and carbon dioxide is CO2. वो 12 और ऐड कर दें, so 44. So oxygen will travel faster as compared to carbon dioxide. So carbon dioxide diffusion in the gaseous media is very slow. That's why we have to breathe in and out to take the carbon dioxide out. To the liquid medium, when it reaches the alveoli and goes to the blood, it's all liquid. Through the liquid, the gases follow the Henry's law of diffusion. Diffusion of gas is directly proportional to its solubility coefficient. जितनी ज़्यादा गैस सॉल्युबल होगी उतनी जल्दी फास्ट ट्रैवल करेगी. कार्बन डाइऑक्साइड इज़ वेरी मच डिफ्यूजिबल एज कम्पेयर टू ऑक्सीजन. अगर दोनों को हल करें आप, इट इज़ 1:20 रेशो. तो कार्बन डाइऑक्साइड फ्रॉम द ब्लड अप टू द नोज इज़ अप्लाइंग बोथ द गैस लॉज इज़ 20 times more diffusible as compared to oxygen. For oxygen, even if the patient is apneic, even if the patient is breathing very difficulty, put the oxygen on the face and it will go on traveling. According to Graham's law of diffusion, it will reach the alveoli and it will go to the blood. But it will be very difficult to bring the carbon dioxide out if the person has got depressed breathing. For that purpose, you will have to ventilate. For that purpose, you have to assist the ventilation also, because it cannot come out, because diffusion through the gaseous media of carbon dioxide is very, very slow. ना होने के बराबर है. Now, once the oxygen goes into the blood and it is carried by hemoglobin mainly. So, this oxygen, when it goes into the blood, it exerts its pressure, which is called PaO2, P small a-O2. Suppose we say we are giving 20% oxygen and lung is good, and it's passing through alveolar capillary pathway and the blood, it's combining with it's exerting its pressure. It is a gas which is present in the plasma, which exerts that pressure, which is called PaO2. Under that pressure, bulk of oxygen is combined with the hemoglobin, right? So the bulk of oxygen is carried by hemoglobin. Now, combining of oxygen from the plasma to the hemoglobin depends on oxygen dissociation curve. Now, what is the oxygen dissociation curve? It is a curve which correlates the partial pressure of oxygen to the percent saturation of hemoglobin. It's a sigmoid shape like this. So, it depends on the three factors again. Now, one is the temperature, other is acidity or alkalinity, third is the level of 2,3 डाईफॉस्फोग्लिसराइड 2,3-DPG। 3, टेम्परेचर ज़्यादा हो जाए, आपकी एसिडिटी ज़्यादा हो जाए, आपका 2,3-DPG लेवल हो जाए, ऑक्सीजन डिसोसिएशन कर्व शिफ्ट्स टू द राइट. It means it's not in association mode, it is in dissociation mode. It does not accept the oxygen. टिश्यू पे जाके बड़ी जल्दी छोड़ देंगी, ठीक. When hypothermic patient, alkalotic patient, or if the 2,3-DPG level is less, then it shifts towards the left. It means hemoglobin is like absorbing paper, so it will accept oxygen very quickly, but it will not give oxygen to the tissues very easily. In past condition में आप देखा होगा, if you look at the ABGs, it shows alkalosis, and when you look at the saturation is 98%, but you look at the PO2 is 65 or 70. That explains the oxygen dissociation curve. Because of alkalosis, oxygen dissociation curve shifted towards the left, it accepted the oxygen very quickly. So प्लाज्मा में ऑक्सीजन की कमी होगी, that will lower the pressure in oxygen. तो उसको आपको सोचना पड़ेगा. Now we'll have to neutralize this alkalosis. If the person is hypothermic, we have to warm the patient. If there is a level of 2,3-DPG level, provide the energy and enhance the activity in the Embden-Merhoff pathway of carbohydrate. दो ही होते हैं ना pathway. Embden-Merhoff pathway के through बनती है 2,3-DPG, वही metabolize होती है. So you will have to think about it. It's a beautiful topic itself, oxygen dissociation curve. इसमें बहुत सारी चीज़ें explain होती हैं. It's a hypothetical, लेकिन reality यही है. चलता है इसी तरह ये ऑक्सीजन कैसे लेके जाती है hemoglobin. So hemoglobin level is very important also, and it should be kept in a mood to accept the oxygen. hemoglobin 19 ग्राम हो, but it is not in a mood to accept it. उसका mood depend करता है 3 चीज़ों पे. One is the temperature, other is acidity or alkalinity, and the third is 2,3-DPG. Now what happens in newborn? In the newborn, PO2 is, it's a newborn, PO2 is around about 60-65. उसको आप ये ना ढूंढते हो, उसकी saturation पे depend कर देखिए आप उसको. Why it is less? Then the second question arises. Number 1, surface area of the baby. If you divide it by body weight, and surface area adult divided body weight, in case of baby it's 2 to 3 times more as compared to adult. It means it utilizes the oxygen too much. From blood it is sucking the oxygen and using it, so the oxygen is left very less in the plasma, so PO2 goes down. Now hemoglobin के साथ कैसे कंपेयर करते हैं? It has got very less affinity to 2,3-DPG. Fetal hemoglobin है, बीटा चेंज में चेंजेस आई हुई हैं, ठीक. तो it has got very less affinity to 2,3-DPG. ये दो साइड्स पड़ी हैं जिसमें ऑक्सीजन ने भी मिलना है हीमोग्लोबिन के ऊपर और 2,3-DPG ने मिलना है. इनका आपस में कंपटीशन है, जिसकी ज़्यादती हो जाती है वो दूसरे से आगे निकल जाती है. अब 2,3-DPG की अफिनिटी नहीं रहती, कम होती है इन न्यू बॉर्न बेबी बिकॉज ऑफ फीटल हीमोग्लोबिन. सो ऑक्सीजन ज़्यादा एक्सेस का यूज़ हो जाती, तो इसलिए सैचुरेशन बड़ी हो जाती है. लेकिन एट द सेम टाइम सैचुरेशन ज़्यादा हो जाए, लेकिन इट डज नॉट रिलीज द ऑक्सीजन टू मच टू द टिश्यूज. तो देखेंगे उनकी सैचुरेशन ठीक है, पार्शियल प्रेशर कम है. इन न्यू बॉर्न वी शुड एक्सेप्ट दैट पार्शियल प्रेशर इज ऑलवेज लेस एट द न्यूनेट्स एज कम्पेयर टू एडल्ट. तो उस पर गुजारा करना चाहिए आदमी को, ठीक है ना. So it's because of two reasons. One is the surface area is greater, and other is it has got less affinity to the 2,3-DPG. Why there is less affinity? Actually, combine other. What is the difference in chemical formula on beta chain? Now, what are the factors which affect the oxygen saturation? Inadequate oxygen availability at the alveoli. Obviously, if it is less oxygen going into the blood, less will be saturated. Then the poor diffusion across the pulmonary membrane. There is availability of oxygen in the air, availability of oxygen in the alveoli, but it's not passing through the alveolar capillary pathway, like in pneumonia, pulmonary edema, COPD. Then ventilation perfusion mismatch. The blood is not coming in contact with the gases, there is shunting effect. That will also causes reduction in saturation of hemoglobin. How much is the carbon dioxide produced in 1 minute? Oxygen we utilize 250 ml in adult per minute. How much is carbon dioxide produced 1 minute in case of adult? 200 ml. 200 ml. 200 ml is carbon dioxide produced and 250 is oxygen utilized. If you make a ratio of carbon dioxide production to the oxygen used, 200 divided by 250, what is the ratio? 0.8, with the same like ventilation perfusion ratio. And this is called respiratory quotient. Carbon dioxide produced divided by oxygen utilized is called respiratory quotient. You must know the respiratory quotient of whole body, respiratory quotient of individual organs, respiratory quotient of any food you are giving to the patient also. Now, diagnostic testing is pulse oximetry. Now, pulse oximetry only tells you, what does the pulse oximetry tell you? आप उसको लगा देते हैं, देखते हैं सैचुरेशन नजर आती है. फॉर एग्जाम्पल एक पेशेंट की सैचुरेशन 100% आ गई. What does it indicate? This indicates oxygen is passing through the lung, coming into the blood, and oxygen dissociation curve in a mood to accept the oxygen. Even if the hemoglobin is 4 gram or the hemoglobin is 20 gram, the oxygen saturation does not quantitate the amount of oxygen there. So saturation only tells you the patency of respiratory system. It also tells you about the patency of alveolar capillary pathway. It also tells you about the oxygen dissociation curve. It does not tell you the amount of oxygen. It does not tell you the oxygen delivery to the tissues also. उसके लिए फिर आपको पूरी ब्लड गैस एनालाइज करके PO2 करना पड़ता है. ना पीक एक्सपिरेटरी फ्लो टेस्टिंग भी करते हैं लंग के लिए, पल्मोनरी फंक्शन टेस्टिंग, जो एंड टाइटल CO2 मॉनिटरिंग कि कितनी कार्बन डाइऑक्साइड बाहर निकली है, लेबोरेटरी टेस्टिंग में arterial blood or venous blood. Now you are giving blood, you are giving oxygen to the patient. You are looking at the saturation, you are looking at the partial pressure of oxygen, and looking at the hemoglobin level. You know how much is oxygen going to tissue. Okay? Now this is delivery of oxygen to the tissues is called DO2, delivery of oxygen. Then you will have to look at the venous blood. वीनस ब्लड की सैचुरेशन देखें, वीनस ब्लड की हीमोग्लोबिन देखें, उससे कैलकुलेट करें उसकी डिलीवरी कितनी है. और दोनों में जो डिफरेंस होगा, दैट इज ऑक्सीजन विच हैज बीन टेकन बाय द टिश्यूज, दैट इज कॉल्ड VO2, वॉल्यूम ऑफ ऑक्सीजन विच हैज बीन टेकन बाय द टिश्यूज. अभी भी हमें नहीं पता whether that oxygen being utilized by the tissues or not. जैसे कार्बोनिक एनहाइड्रेस, नहीं सॉरी, ये क्या होता है साइनाइड पॉइजनिंग में, तो ये ऑक्सीजन को यूज़ नहीं करने देती टिश्यूज़ पे. ठीक है, ऑक्सीजन पहुंच गई है, एक्सट्रैक्ट कर ली है, लेकिन इस्तेमाल नहीं करने देती. हाँ, तो उसके लिए फिर क्या होगा? मेटाबॉलिज्म गोइंग ऑन ऑल द टाइम, मेटाबॉलिज्म कभी नहीं रुकती. अगर ऑक्सीजन दे देंगे एरोबिक मेटाबॉलिज्म होगी, अगर ऑक्सीजन नहीं देंगे एनारोबिक मेटाबॉलिज्म होगी. अगर ऑक्सीजन देंगे तो कार्बन डाइऑक्साइड प्रोड्यूस होगी और एनर्जी. अगर ऑक्सीजन नहीं देंगे उससे फिर लैक्टेट बनेगा, एसिड्स बनेंगे. तो आपको ये ज़रूरी है ब्लड गैस के साथ लैक्टेट भी देखें कि हम ऑक्सीजन दे रहे हैं, पार्शियल प्रेशर ठीक है, टोटल अमाउंट ऑफ ऑक्सीजन डिलीवरी ठीक है, एक्सट्रैक्शन भी ठीक है, वेदर ऑक्सीजन बीइंग यूज्ड और नॉट, उसको देखने के यू हैव टू लुक एट द लैक्टेट आल्सो. जब यहाँ तक कर लेते हैं, इट मीन यू हैव टेस्ट द ऑक्सीजनेशन ऑफ ए पेशेंट, तब कंप्लीट होता है. अगर मैं किसी को पकड़ाऊँ कि ये पेशेंट है, इसकी हिस्ट्री है, इसका ऑक्सीजनेशन स्टेटस मुझे बताओ, उसको इसी तरह बताना चाहिए कितने % FI2 है, कितना उसका PaO2 है, कितनी सैचुरेशन है, उसकी DO2 इतनी है, VO2 इतनी है, लैक्टेट इतना है. जब तक लैक्टेट तक नहीं पहुँचेगा, आई विल नॉट बी सेटिस्फाइड वेदर द ऑक्सीजन स्टेटस हैज़ बीन चेक्ड और नॉट.